All right, doctors, welcome. Today, we're going to tackle a topic that is absolutely huge for your AFK exam, dental traumatic injuries. You really have to know this stuff inside and out, so let's get you prepped. So where do we see this the most? Well, think about it. It's usually kids, right? The peak age is right in that 7 to 12-year-old range. And what gets hit? Yep, it's almost always those maxillary anterior teeth. We're talking falls, playground accidents, the classic scenarios. So here's how we're going to break this down. We'll start with the basics, assessment and diagnosis. Then we'll jump into fractures, then luxation injuries. After that, we'll hit the big one, avulsion, which is a true emergency. And we'll wrap it all up with a rapid-fire recap of the key numbers you just have to remember for the exam. Okay, first things first, assessment and diagnosis. These are the principles that apply to every single trauma case you're going to see. Getting this part right is absolutely foundational. Now here's a huge potential pitfall, pulp testing. Right after an injury, that tooth is basically in a state of shock. The nerve conduction is all out of whack. So if you do a cold test or an EPT and get a negative result, don't immediately jump to conclusions. It's very often a false negative. The real key here isn't that first test. It's about getting a baseline and then watching the trend over time. That's what's going to tell you the real story of the pulp's vitality. And then there's the follow-up schedule. Honestly, this is just straight-up memorization for the exam. The sequence is 3 weeks, 3 months, 6 months, 12 months, and then annually. If you need a little trick to remember it, just start with the threes. 3 weeks, 3 months. Then add them together. 3 plus 3 gets you to 6 months. And then just double that, and you're at 12 months. Easy enough, right? Now, when it comes to radiographs, one shot is never enough. Never. The IADT, the International Association of Dental Traumatology, they set the standard, and it's at least 4 different views. You need your straight-on 90-degree periapical, 2 more PAs with different vertical angulations, and 1 occlusal film. Why so many? Because you're looking for things that hide, like root fractures or displacements that a single angle will absolutely miss. This is the standard of care. Okay, so that's diagnosis. Let's move on to managing the fractures themselves, the hard tissue injuries. And really, the treatment for these all comes down to one critical question. Is the pulp involved or not? This table makes it super clear. You've got an infraction, just a little crack in the enamel. We just watch it. No big deal. Then you have an uncomplicated fracture where you've lost some enamel and dentin. Here, your main job is to seal off that exposed dentin. Simple enough. But once that pulp is exposed, it's a complicated fracture, and the whole game changes. Now, your #1 goal is keeping that pulp alive. We're talking vital pulp therapy, pulp caps, pulpotomies, whatever it takes to maintain vitality. Okay, get ready for a classic exam question. You've got a crown root fracture that goes subgingival. Do you do the perio or the endo first? The answer is always perio. Think about it. Why would you do a root canal on a tooth you can't even restore? You have to figure out if it's restorable first. That might mean a gingivectomy, maybe even orthodontic extrusion, but you have to establish that sound restorative margin before you even think about starting the endo. Restorability dictates everything. With root fractures, what's our game plan? Well, first, you get that coronal piece back where it belongs. Then, you stabilize it. We're going to use a semi-rigid splint for about 4 weeks. And what are we hoping for? We want to see some good healing, maybe with calcified tissue or connective tissue knitting those pieces back together. What we absolutely don't want to see is inflammatory tissue getting in there between the fragments. That's a sign of non-healing, a sign of failure. All right, we've talked about fractures, which is damage to the tooth itself. Now let's shift gears to luxation injuries. Here, the primary problem isn't the tooth, it's the stuff that holds the tooth in place. We're talking damage to the PDL and the alveolar bone. Pay close attention here because this table is pure gold for the exam. First, the easy ones. Concussion and subluxation, no splint needed, just some TLC. The ones you have to know the difference between are extrusive and lateral luxation. Extrusive, where the tooth is coming out a bit, that gets a flexible splint for 2 weeks. But lateral luxation, where it's pushed sideways and usually breaks some bone, that needs more time. That's a longer splinting time of 4 weeks. 2 weeks versus 4 weeks. They love to test you on that. Here is a clinical sign you need to have locked in your brain. If you percuss a tooth after trauma and you hear a high-pitched, metallic tink sound, that's a huge red flag. That sound means there's no PDL space left. The root is literally jammed up against the bone. And what happens when root touches bone? Ankylosis. That metallic sound is the sound of future replacement resorption. Okay, let's talk about the big one, the true sirens blaring dental emergency, avulsion. The tooth is completely out of the socket. Here, time isn't just a factor, it is everything. What you tell the patient or parent on the phone before they even get to your office can literally make or break the outcome for this tooth.
So what are those critical on-site instructions? First, best case scenario, gently rinse the tooth and stick it right back in the socket immediately. That gives it the absolute best chance. But if they can't do that, the next best thing is proper storage, and the magic medium is milk. Why milk? Because its physiological osmolarity is just right to keep those delicate PDL cells on the root alive. The absolute worst thing they can do is put it in water. Water's hypotonic and it'll cause the cells to burst. So milk is the way to go.
Now, the patient's in your chair. Your entire treatment plan hinges on one single question. How long was the tooth dry? The magic number is 60 minutes. If it's been dry for less than 60 minutes, your mission is to save the PDL cells. Be gentle, rinse the root, and replant it. But if it's been dry for more than 60 minutes, those PDL cells are considered non-viable. Your mission changes completely. Now it's about preventing inflammatory reabsorption. You'll actually need to mechanically remove the necrotic PDL and often treat the root with fluoride before replanting. Two totally different philosophies, all based on that 60-minute mark.
Okay, the tooth is back in. What's next? There's a whole checklist of things to do. You'll put them on systemic antibiotics. Doxycycline is a common choice to prevent bacterial contamination. You'll prescribe a chlorhexidine rinse to keep things clean while they can't brush the area properly. And this is a big one that's easy to forget. You must check their tetanus immunization status. If they're not up to date, you need to refer them for a booster shot.
All right, let's wrap this all up with a super quick, high-yield recap. If you remember nothing else from this, remember these numbers for your exam. 2 weeks. What's that for? That's the splinting time for an extrusive luxation and also for a simple avulsion. 2 weeks.
4 weeks. When do we use that? For a lateral luxation? Remember, that's the one that usually involves a bone fracture. And also for root fractures. 4 weeks.
60 minutes. This is the golden hour, or maybe the deadly hour, for an avulsed tooth. This is that critical extraoral dry time that changes everything about how you treat it and its prognosis. And for our final thought, let's put it all together with a clinical scenario. A patient comes in, had trauma years ago. The tooth now looks kind of yellowish, and it tests non-vital. What are you thinking? Well, that yellowing is from pulp canal obliteration, calcific metamorphosis, but the key is that it's now progressed to pulp necrosis. So what's your next step? You got it. You're going to initiate root canal therapy.